registers at the Conquest. And I'm just going to take you through a bit about aortic stenosis and TAVI. So what we'll do is cover some simple sort of anatomy about normal heart and aortic valve and a little bit of echo. Just bear with me. I'm going to start from a pretty basic level just because it's important to understand the simple things to appreciate how we go about doing TAVI. So we'll talk a little bit about aortic stenosis, how patients present and how we investigate them. And then when we consider intervention for aortic stenosis, we'll also talk a little bit about what TAVI involves, because I think it's really important. We all come across aortic stenosis looking after an aging population, and it's really important to know what you're actually suggesting putting the patient through when you talk about whether it might be appropriate to intervene. We'll also talk about sort of frail patients and when you should think about TAVI versus medical therapy, and then fitter patients and how recent research has influenced how we manage these fit people who would conventionally have had surgery, but nowadays we might consider TAVI. So from the very beginning, this is the heart if you were to open the chest, and you can see that the right heart is anterior, so closer to the chest wall, and then the left heart and the aortic valve sits slightly behind the right heart structures. And again, that's clear here where you can see the bluer right heart structures overlying the redder left heart structures. And this picture demonstrates quite nicely what the aortic valve actually looks like. So you can see it looks very different to the mitral valve. The aortic valve has got 3 cusps there that open and close in systole and diastole, as opposed to the mitral valve, which is sometimes described as a sort of a fish mouth-like structure, which is supported by the left ventricular muscular wall. Now, it may be beyond me to share this image, but we'll have a little go. So I'm just going to show this video simply because I think it demonstrates very nicely the structures within the heart and how the anatomy differs from one valve to another. So you can see the SVC and the IVC coming into the right atrium, the blood crossing the tricuspid valve into the right ventricle, then the blood going out of the pulmonary valve into the pulmonary artery. And the pulmonary valve there looks quite similar in appearance to the aortic valve, as we'll see as we come across to the left side. And here you've got the blood draining into the left atrium via the pulmonary veins, crossing the mitral valve into the left ventricle, and then exiting the left ventricle out of the aortic valve. And the way that we access the aortic valve in TAVI is actually to go into the artery and then arch back round across the aortic arch and come across the valve from above. So let me see if I can just bring that presentation. Yeah. So I'm going to show you an echo image next, and I know that not everyone looks at echo every day, and there's one simple thing I want you to look at in this picture. So this is one of the typical views that we look at. It's called the parasternal short axis. But all I'm going to ask. I hear quite a lot of noise there on the Teams chat now. Was someone asking a question, raise an issue, or just hadn't realised the microphone was on? Okay, fine. So I'm just going to bring my presentation up again. So with this echo image, I want you to focus simply on the very middle of the screen where you can see the aortic valve. And this shows a normal aortic valve opening and closing. So if you recall what we were just looking at with the 3 cusps opening and closing, they're nice and thin and they're easily mobile. That is a normal aortic valve. We're going to talk through a case. So this is Mr. TS, who's a 76-year-old man usually fitting well, and he's a runner. And up until a few months ago, he could run 10 kilometres without any problems at all. And now he's becoming gradually more breathless on inclines. So what else might you like to ask Mr. TS? Anyone want to volunteer any suggestions, either speaking or through the chat? Maybe you can write them down if you're a bit worried about talking in front of everyone. There'll be a few opportunities to do this along the way, and hopefully it'll make it a bit less dry. So you want to ask a bit about his breathlessness. Is he just breathless on exertion? Is he getting breathless at night? So is he getting any paroxysmal nocturnal dyspnea or orthopnea? Is he having to prop himself up in bed? And then, as this is a talk about aortic stenosis, you need to think about other symptoms of aortic stenosis. Now, I'm just going to flip back to this picture here, and you can see here that just above the aortic valve, these are the coronary arteries, and they provide blood flow to the heart muscle itself. So if this valve is stiff and not much blood is getting across it, then the symptoms that you're likely to get are going to be angina, because you're not getting enough flow to the heart muscle through those coronary vessels, and syncope or pre-syncope. So you're going to feel faint because you're not getting enough flow up to the head and neck either. So these are some of the classical symptoms of aortic stenosis. On examination, so again, just going to give you a moment here to write down what you think you might find in someone who's been breathless on exertion in a talk about aortic stenosis. Anyone brave enough to volunteer any suggestions? Yeah, Serena, great. So you might hear a pansystolic murmur. And what features might suggest that this was a severely stenosed valve as opposed to just some stenosis? So being unable to, yes, so may well radiate the carotids, and that is just, typical for aortic stenosis. Features that suggest the stenosis might be severe are if you cannot hear the second heart sound because the valve is so stiff that actually it doesn't close very loudly. The other thing you might notice is a slow rising pulse, suggesting that the blood flow in systole is really, quite, constricted as it's trying to get across that stenosed valve. And of course, you get a forceful apex because the left ventricle is having to work pretty hard to get the blood across the valve. So here I've just, I think everybody knows what aortic stenosis sounds like. So I'm just going to play this very briefly. So you've got your normal sounds quickly here. And then you've got your AS. Now this is an echo showing aortic stenosis. So at the top, we've got that normal valve that we looked at before. And at the bottom here, you can see these three cusps, and I'm going to draw along the line where they meet together, making sort of a Mercedes-Benz type sort of image. But you can see that they're really thick and very white. So there's a lot of calcification here. And I think you can probably appreciate from these images that the valve is barely opening. And I'm not going to show you too much echo at the risk of losing some of the audience, but our physiologist very kindly helped me out with some of these pictures. And I think it would be a bit heartbreaking if I didn't at least show you the 3D image of the valve. So this shows, the valve in 3D, and you can see that it's very thick and it's barely opening. Right, so what do we look at on echo? So we look at the valve itself and we make a visual assessment of what does it look like. And we try to think, why has this person got a stenosed aortic valve? And anyone know what's the most common cause of, the aortic valve being stenosed? No one's jumping to answer. So yeah, calcification, brilliant, Johannes. Yeah. So we'd call this sort of degenerative calcific aortic valve disease, and that might be of a tricuspid aortic valve. So that's the normal structure of the tricuspid valve. Why might a younger person develop aortic stenosis? Yes, so if they've got a bicuspid valve, so they've only really got two cusps that open and close, it might be that two of them are fused together. So really they've only got, effectively two. But this puts the valve under greater stress and strain, and it means it degenerates and becomes sort of stenosed much earlier in life. Great. What about if you notice that the mitral valve looked pretty abnormal and quite thickened and quite stenosed, as well as the aortic? What might that make you think of? Yeah, so brilliant. Rheumatic heart disease. So it's important to think about, why has this patient got aortic stenosis? Because it has implications. So a bicuspid aortic valve is associated, it's a congenital problem, and it's associated with abnormalities of the aorta in general. This person might be at risk of having a dilated aorta and aortic dissection, as might their family, as it's a hereditary condition and it would warrant screening. And we've already said that if you're worried about rheumatic heart disease, you should be looking at the other heart valves, and mitral stenosis is very common if you've got rheumatic heart disease. The other thing we look at is how severe is aortic stenosis. So if the valve is narrow, the same amount of blood still has to try and cross the valve. So it has to go much faster to get through that narrow opening. And one of the main ways in which we assess severity of aortic stenosis on echo is to look at the speed at which it crosses the valve, and to actually measure the blood flow and look at the gradient or the steepness with which the blood is crossing the valve. And we can use this to calculate the valve area. So clearly a smaller valve area is associated with a more severely stenosed aortic valve. We look at how well is the heart coping in general with the aortic stenosis. So if you've got severe aortic stenosis, the left ventricle can start to struggle. If you think back to that little video at the beginning, the left ventricle has to push the blood across the aortic valve. The muscle gets thickened, so you get left ventricular hypertrophy, and then it can start to fail. There can be back pressure on the mitral valve, which can start to leak. And then the left atrium gets bigger and bigger. And then the right heart struggles more and more to push the blood to the lungs and back into this high pressure left atrium. So these are all signs that the valve disease is severe and that the patient's not coping well with it. So the patient we looked at, we've already seen some images. So he's got a degenerative tricuspid aortic valve. I can tell you that these numbers suggest that he's got, severely stenosed aortic valve. So he's got high gradients and a low valve area. So when do we think about intervening? So patients that have severe aortic stenosis with symptoms, or they don't have symptoms, but you're concerned the left ventricle is struggling. So either their ejection fraction is reduced on the echo, or their BNP is raised, or the right heart struggling. And for those who are interested, you might recognise that pulmonary artery systolic pressure is one indicator of right heart functioning and pressures. Very high velocities across the valve, and problems when they try to exercise. So either when they exercise, they get their symptoms, or their blood pressure falls. Now, one thing that makes our life quite difficult is when the left ventricle is not working well, it's quite hard to push the blood across the stenosed valve at a high speed. So therefore, you might be looking at the echo and thinking, I think that valve is barely opening. However, the speed I'm getting across the valve of the blood flow isn't in keeping with severe aortic stenosis. And that's what we call low flow, low gradient aortic stenosis. So it's simply that the left ventricle can't generate a high flow across the valve, and therefore you're never going to measure a high velocity or high gradient necessarily. So what would people do for Mr. TS? He just gets a bit breathless when he goes up inclines, but he does have severe aortic stenosis. Anyone want to volunteer what they would suggest they would do? Right, no takers, so we'll crack on. So he actually went on to have an exercise test, and I guess this is probably because of the fact that it's quite mild, his symptom burden, really. Okay, so who would you do an exercise test on? So really, you should only be thinking about doing it in young patients with severe aortic stenosis without, convincing symptoms. So if you put an old, frail person with severe aortic stenosis on a treadmill, it will go badly. So hopefully that part of things is relatively obvious. What do we do? So usually exercise tests, we do something called the Bruce protocol, where the speed and the incline of the treadmill increases every few minutes. And we would use the modified Bruce protocol for AS. This is where there's a couple of really gentle warm-up rounds at the beginning to check that you're not going to bring the patient to harm by putting them through the test. And we check their symptoms, their blood pressure, and their ECG regularly. You should stop the test if you get symptoms, if the blood pressure falls significantly, or you're worried about ECG changes. And the things that you'd refer to as a positive test, suggesting that the aortic stenosis is significant, are the development of symptoms, which are classic for aortic stenosis, a significant drop in blood pressure, and VT or new AF. So he had a stress echo, this man, and his gradients went up massively. He also had an angiogram. And really, there are two reasons you can think of why he's had an angiogram. The first is because, if you're thinking about intervention, which might include open heart surgery, it's very embarrassing to put a patient through valve surgery and then learn 2 years later that they needed a coronary bypass graft whilst they had their operation. Secondly, his symptoms of mild breathlessness on exertion in his 70s, it's quite a non-specific symptom, and you need to think, is it really because of aortic stenosis? So occasionally patients, rather than having typical anginal chest pain, can get breathlessness with coronary disease. And he was found just to have some mild coronary disease, for which he was started on the statin and some aspirin, awaiting a decision about what to do for his heart valve. So perhaps we need a bit more information to decide what to do with him. So what does TAVI involve? So in TAVI, this is usually done in the cardiac catheter labs where we do angiograms and pacemakers. And patients, there is an anaesthetist, cardiac anaesthetist present, and patients are given what is called conscious sedation. So they're drowsier than when you just give them a little bit of diazepam to do an angiogram. And then they're less deeply asleep than when they would have a general anaesthetic. There's access from the patient's right arm arteries to allow us to put a little device in between the main vessels and the head and neck to try and reduce the risk of stroke, almost like a little filter to try and catch anything that tries to fly up during the procedure. There's access from the left arm, and what we do is just put a little catheter or tube at the aortic root, so where the aorta begins, because the whole procedure is done just through X-ray guidance. So you're looking at the patient's chest under X-ray, and at least this way you can see something that's radiopaque in the position of the aortic root to guide you towards the aortic valve. And then the main bulk of the procedure is most usually done via the groin or the femoral artery. So quite a large tube is put in the femoral artery, and that allows a wire to be threaded up round the aorta into the position of the aortic valve. And then once you put this device into the native calcified aortic valve, either expands by itself, or you open it up via a balloon, and this new valve sits inside the old calcified aortic valve. And then we do what we call take a final shot of the leg. So this is where you've put your big tube into the femoral artery, you inject some dye and check you haven't caused any problems with the arteries in the leg. And then patients go to CCU afterwards. And in Brighton, where I've come from, where they're doing a lot of these procedures, patients are going home 24 to 48 hours later if the whole thing was straightforward. This is what one of the TAVI valves looks like. And this is how I was describing, the tube going up the aorta, round the arch, and sitting inside the original native calcified valve and being opened up. So benefits: relieve symptoms of aortic stenosis, less admissions for pulmonary edema, live a bit longer. Risks: stroke, death, needing a pacemaker. So this valve goes up just adjacent to the conducting system of the heart, or the left bundle, and therefore transiently or more longer termly you can damage the conducting system of the heart and patient might need a pacemaker. The risk of pacemaker depends on what type of TAVI valve you're putting in and what the patient's ECG looked like before the procedure. So if they already had a right bundle branch block, you're potentially giving them a left bundle branch block by doing the procedure, and the likelihood of causing significant conduction issues is much higher than someone with, sinus rhythm before the procedure. And vascular complications are the big one for anyone who's worked in a TAVI centre, is that being called to see the patient who's developed shock because of bleeding in the groin. And you can actually rupture the aorta itself. So a lot of these patients have really calcified aorta as well as aortic valve, and suddenly opening a balloon within it can be problematic. So we said there are two questions really around TAVI. So for the frailer patients, you're thinking, will I do nothing or will I do TAVI? But increasingly we're saying for fitter people, will I do surgery or will I do TAVI? And that's really, I think, what we're thinking of with this, fit chap in his 70s who runs 10K all the time. And to make that decision or to start to think about it at all, you need to know what are the risks of surgery. So I spoke to one of my surgical colleagues and said, can you consent me as though I was this gentleman for aortic valve surgery? And he began by saying, I always start by telling patients that without intervention, if you've got severe symptomatic aortic stenosis, mortality at 2 years is 50%. So then, of course, he went on to list all the complications and it didn't sound so bad. So he counsels people for bleeding, infection, wound complications. Going on to bypass for your heart and lungs is not as good as having your heart pump blood out to them. And you can end up with any organ failure as a result of hypoperfusion. And that relates partly to the time that you need to be on bypass. AF is quite common, a lot go back to sinus rhythm. Pacemaker again is, sometimes an issue. It can get infection, can get a leak around the valve that's put in. This is less common than with TAVI because it's stitched in very carefully under direct vision as opposed to just being put up in a balloon against an existing valve. And the reason why people are offered metal valves if they're younger is because tissue valves can degenerate. And nowadays, the surgeons in Brighton are actually consenting people for COVID because you have to come into hospital and stay in the ward. So how do they assess? And then the big ones are stroke and death, and that is unique to the patient. So use a system called Euroscore to calculate this. And it won't take very long to quickly show you for this man at the age of 76 with no significant past medical history, a good left ventricle, an elective procedure that's not a cabbage but is valve, then his risk of death or stroke around the procedure is less than 1%. So this calculator is not very good at taking into account frailty or liver disease. both of which are a bit of a disaster if you're thinking about open heart surgery, but of course not relevant to this man. And this is what they do with surgery. They put in either a tissue valve or a metal valve after they take out the native stenosed valve. So what are the advantages of surgery? So as I said, it's a bit more precise, so you might get less leak. We don't yet know how long TAVI lasts and how well it does for people. So if you're looking at a young person, you're probably better off thinking about referring them to the surgeons and talking about a metal valve. And surgery lets you do bypass grafts. TAVI doesn't let you intervene on coronary disease. What sort of things do we look for day one after a TAVI? Are they alert and orientated? They've not sort of had a stroke or had low blood pressure during the procedure. How's the groin? So if you've got bleeding that you can see at the groin, it's all very easy. You can put pressure on that and see how it goes. However, what can happen is that the back of the vessel wall is damaged and you actually have bleeding that you do not see any sign of by looking at the groin because it's going into the retroperitoneal space. And the way that you'll know about this is the patient becomes shocked, their blood pressure drops, their hemoglobin drops, and they need a CT scan or a conversation with the TAVI team, who sometimes just take them back to the lab, inject the contrast and put a stent in to fix this. How's the valve? So listen to see, can you hear any aortic regurgitation? And again, this is just here to listen to. So quite different to your aortic stenosis. And how's the heart rhythm? We've said we can cause problems with conduction. And that's why you need to look at their medicines as well. Check they're not going to be given their beta blocker, having developed complete heart block. So this was this gentleman before his procedure. And anyone wants to volunteer the most striking abnormality about his pre-procedure ECG? See that our lead physiologist has joined the conversation and can probably tell us what's wrong with the ECG. That was a bit mean, sorry, Ben. Yeah, so Yasser said it's a bundle branch block and it's a right bundle branch block. So that's your typical marrow pattern where you've got your M in V1 and your W in V6. And then sadly, the procedure has caused a left bundle branch block. And this ECG shows him requiring some temporary pacing. So you can see the little pacing spikes here. You can see there's not a relationship between the P waves. Sorry, it's a bit tricky to hear you there. Can you say that again? Sorry, if you can repeat the question. Okay, sorry, we'll carry on, but if you want to ask a question, just put it on the chat there and I'll come back to it. So yeah, sorry, the atrial activity is independent of the ventricular activity. So P wave, swallowed up P wave, another P wave, and you can see the QRS is very broad because it's coming from the ventricles where this temporary wire is. And some of these settle with time. That one didn't, so he required a pacemaker. Now, we've talked about Mr. TS, this fit chap in his 70s with a very low surgical risk, who actually he went up to London for an opinion, and they said, well, you know, we would feel most comfortable with offering you open heart surgery rather than TAVI. And then a year later, he said, you know, I don't want that. A year later, he came to Brighton and was offered a TAVI. And we'll come back to that at the end to discuss a little bit about what might have changed in terms of our understanding of the risk benefit in that situation. But the other thing I think to highlight here, and something that you'll probably come across much more commonly in general medicine and across specialties, is the frailer patient who has aortic stenosis amongst many other issues. So let's talk about Mrs. ES. So she's 77 and she's breathless. And she does have aortic stenosis, which is severe, but she's also got left ventricular systolic dysfunction. So her pump doesn't work very well, maybe because of the aortic stenosis, maybe not. Diastolic dysfunction, so her left ventricle doesn't relax very well to fill with blood, and it's a bit stiff, therefore it's not very efficient when it pumps out blood. She gets atrial fibrillation, and occasionally her rate is a bit uncontrolled, and that doesn't help. And she's also got COPD, and she's generally quite frail, so she uses a stick to get around inside her house. And since COVID, she hasn't been going out very much. So there's probably some loss of physiological reserve here as a factor in her fitness and her breathlessness. So what you need to ask yourself is this lady breathless because of her aortic stenosis? Because if she's not breathless because of her aortic stenosis, but because of other things, then firstly, the natural history and prognosis of someone without symptoms from severe aortic stenosis is better than somebody who's symptomatic from aortic stenosis. So there would be a case for saying that there might be less harm from not intervening. And secondly, if you do a TAVI, her breathlessness may not get any better at all if it's actually caused by other things. And clearly it's very difficult in this situation to work out what is the biggest problem and whether you would or wouldn't need to do anything about her aortic stenosis. And really, it wouldn't be unreasonable in this situation, someone with severe aortic stenosis and symptoms which might be attributable to it, but other problems. It wouldn't be unreasonable to speak to us and ask advice. But we would love to hear what you think might be underlying her symptoms, whether it's mostly the AS or could be other factors, just so that we understand what benefit they might get from a procedure, but also to know a little bit more about Mrs. ES and how she manages day to day, to understand how well she would or wouldn't potentially tolerate a TAVI. And the outcomes from TAVI since its beginnings in the UK have got steadily better, and that's partly because people have learned how to do the procedure well. But we think it's a lot to do with selecting the right patients to go through the procedure. So really frail people still might really struggle to have a TAVI successfully and may not, in retrospect, feel that it was the right thing to put them through. And the classic thing really is for somebody who's gets a bit muddled, actually having some sedation and for the procedure and a hospital admission, and sometimes blood pressure can be a bit low for a bit during the procedure for various reasons or complications. And, it can be quite a knock to cognition, perhaps sometimes temporarily and other times longer term. So what informs our decision making about who to TAVI? So the initial study really was the partner trial back in 2010. And this looked at people with severe aortic stenosis and symptoms who aren't surgical candidates, so these frailer people. And, of course, aortic stenosis is predominantly a disease of older people who've had a lifetime of, degeneration of their aortic valve. So a good proportion of people with severe symptomatic aortic stenosis are not open heart surgery candidates. So for half of the patients in the study, they got standard therapy and the other half got a TAVI. And standard therapy amounted to treating any heart failure, stopping any medicines that aren't got a severely stenosed aortic valve. And it also included balloon aortic valvuloplasty, where this was felt to be appropriate. So this is simply inflating a balloon within the aortic valve. Similar route to TAVI, going from the groin there and just opening the balloon up and trying to push apart the calcified cusps of the aortic valve. And they looked at death as the main outcome. And the only thing I want you to take away from this busy slide is that the Euro score, so the surgical risk score, is pretty high. So our man, his was 0.79%. And these patients, you're looking at 26 or 30% risk of stroke or death from open heart surgery. And then the rest of the slide just demonstrates that they had a lot of comorbidities. So what did they find? So the rate of death at 1 year, for any reason, was lower in the TAVI cohort. They were less likely to be hospitalised as well, which some people might argue may be as important. So perhaps when I get to my frailer days, it will matter to me more to not be coming into hospital all the time rather than to be living longer. I mean, don't know, and a lot of people have very good quality of life in their frailer days, but it's important. And symptoms. So the TAVI cohort were much less likely to still have significant breath, for example. There was more stroke. Of course, you are opening a valve within a really calcified native aortic valve, and you can throw off bits of valval calcium, and that can cause a stroke. And of course, there were more problems with, bleeding vessels because you're doing this procedure. And did it last well? Well, they looked just 1 year after the procedure, and the TAVI valve seemed to be performing pretty well. And interestingly, quite a lot of the standard therapy group, the non-TAVI group, had a balloon aortic valvuloplasty. And it didn't really seem to help when you compared that with just medical therapy. And there was still quite a bit of death at 1 year despite that. Okay. So that's talking a bit about the initial premise for TAVI in frailer patients who aren't surgical candidates. So opening up a line of treatment to a lot of these really symptomatic people with quite high mortality if they're not offered any intervention, and saying, look, we think it's safe and it improves outcomes. Again, not very relevant to our man, Mr. TS. So last year, there are a couple of studies, one of which was the Partner 3 study, which looked at surgical candidates, so people with low surgical risk. So severe AS, low surgical risk, average age was in the low 70s, and there were 1,000 people in the study. So they either got a TAVI or a surgical aortic valve replacement, and they compared, these important outcomes at 1 year. So they found that even in this low surgical risk cohort, the TAVI people had less death, stroke, and rehospitalization at 1 year. They had less AF, and they stayed in hospital for less time, obviously. And they were more likely to get home and be self-caring after or their intervention. And this is just a slide from the valve makers showing these findings from the study. So this is the death, stroke, and rehospitalization of surgery compared to their TAVI valve, and there was much less of these bad outcomes in the TAVI cohort. And they said their quality of life was better even at a year. So the red bars being the TAVI people, and saying things had improved compared to the grey bars being the surgical valve replacement people, saying things had improved. And actually in this big study, and in the other sort of Evolute trial, which came out last year as well, looking at a slightly different type of TAVI valve, there wasn't so much vascular complications or need for a pacemaker. And although these valves are a bit more leaky than the surgical valves, it was only really a mild leak that was more common. And that's not very clinically significant. It did affect the conduction system more than the surgical option. So why aren't we just doing it on everyone now, not referring people for surgery? So, I mean, I think the problem here is that these are 1-year outcomes. We're not looking at the longer term. And these are experienced operators doing these trial procedures. And we're looking at one type of valve here. But again, the only thing to take out of this busy slide is that the Euro score, so the surgical risk of death and stroke in these patients in this study last year was really quite low, so 1.5%, much more comparable to Mr. TS and applicable to him when you're thinking about decision making. That is it. So does anyone have any questions or comments? Oh, here we go. So do you thrombolyze if the patient gets thromboembolic stroke during the TAVI procedure? So I had a conversation actually at the time of, when I was working in Brighton and there's a lot of TAVI going on there, I had this conversation with some of the TAVI people. And on the whole, it tends to be most commonly small events, and it's debatable how much of the stroke that you see is to do with little bits that are, as opposed to dislodging major clots. And I think certainly you'd have most likely these are going to be patients who aren't meeting the criteria on the NIHSS scale to thrombolyze, because it's likely to be a small vascular occlusion. And I think if you're in the position where it is a larger territory and they have significant deficit and high NIHSS score, it would be a conversation, an urgent, obviously, conversation with the TAVI operator. Because often what you'll find is that the procedure notes is pretty brief. And when you actually have a conversation with them about how did the procedure go and what would the risk of bleeding for this patient be like, you'll find a whole lot more out by having a conversation with the operator than by reading their procedure notes. So if you learn that the procedure was completely straightforward, uncomplicated, no issues with the femoral arterial access, and the patient's just gone and had a massive stroke that you think is thromboembolic with a big deficit, then you're quite likely to consider the risk benefit of thrombolysis. However, if you have a conversation with the TAVI operator and they say, oh, to be honest, it was very difficult femoral arterial access, or we actually even did this new thing where we went transcaval, we went, IVC crossed into the aorta, there was a bit of retroperitoneal bleeding, then that would be a bit mad to thrombolyze that patient. So I think it would be a case of, so they say, their answer was, it's often a very small stroke. Sometimes it's calcified bits of stuff rather than clots, and therefore the benefit you'd gain from thrombolysis would not necessarily be there. And if it was a big stroke with a big deficit, then you should just call the TAVI operator whatever time and say, is it really the right thing here to not thrombolyze this patient with a big deficit?
Becky, Stephen Fong here. Thank you so much for this presentation on the TAVI for Grand Round. It's been really interesting. Oh, I think you got one question here from another audience. Any sutures required for TAVI?
So often what we do is something called an angioseal. So, and again, this is used in femoral angiography. So it's a device that puts a suture into the vessel without you being able to see the vessel, but they are a bit flawed and sometimes do not deploy very well, and that's likely to manifest in so you don't go back and you'd like to see a visible kind of swelling over the groin if you've got bleeding anteriorly where you've made your incision, and it's just a case of putting pressure on yourself physically as a person, and then when things start to improve, we've got devices like FemStop which apply that direct pressure.
Thanks, Becky. Becky, I've got a question, more something I get a lot from junior doctors who see aortic stenosis patients in say a medical assessment unit, when they come in with maybe other problems, they get a bit jittery about adjusting any antihypertensives or other medication or giving lots of IV fluid. So I didn't know you had like a top 3 tips for junior doctors when you're dealing with a aortic stenosis patient who comes in regards to antihypertensives and fluid resuscitation. Is there any particular advice you give?
Yeah, so that's a good point. So firstly, with medicines in severe aortic stenosis, if a patient has had surveillance for their AS over the years and now it's more severe, really should be taking a quick look at their medicines. And the classic example here is that ACE inhibitors, if you've got severe aortic stenosis, can be felt to introduce risk in the sense that they'll reduce how much blood flow you're managing to get across your aortic valve, and they're lowering your blood pressure, and therefore affect you should be thinking about stopping them in severe AS. But you have to think about why the patient is on the drug and what you're doing by stopping the drug, because if they've just got moderate aortic stenosis and they've got some left ventricular systolic dysfunction, we know that ACE inhibitors are prognostic for heart failure, and they also reduce, admissions with pulmonary edema. So I think it wouldn't be unreasonable when you're reviewing a patient's drugs, if it's not something you're confident with, to discuss it with your, registrar or consultant. And then in terms of managing patients acutely, so these are not patients that are going to tolerate really low blood pressures very well, because they rely on a normalish at least blood pressure to get blood flow across the valve. And when you're giving them fluids, you shouldn't be giving them a litre of fluid as a bolus, for example, to fluid resuscitate them. This is the kind of person where I would give, if I thought they were dry and they needed fluid resuscitation, I'd give 250 mils of fluid, and I'd measure their heart rate and blood pressure before and after, and then consider another bolus and give the fluid pretty gently, and check, make sure that there's I've safely thought about how would we recognize if this patient getting fluids with severe aortic stenosis was becoming a bit wet or developing pulmonary edema. So saying to the nurses, if their respiratory rate goes up, if their SAPs go down, please let me know and I'll come back and see them sooner. Or having handed over to someone else, if you're going off shift, to come and reassess them and check you're not causing harm with giving fluids. Does that help?
I think that's really, really practical advice, Becky. That's brilliant. I think you got another advanced question here. Are you aware of any data relating to the benefit of valve-in-valve TAVI versus SAVR in patients with existing tissue AVRs? That's a little bit above my pay grade, but maybe you can answer that.
So I think Ben's asking me that because I tried to make him tell us about the ECG. So we do put TAVI valves inside, existing valves. So there's TAVI in TAVI and TAVI inside a surgical valve. And I'm not sure of the current evidence base, Ben. I know that we do sort of discuss patients in an MDT setting, and it's partly the anatomy that helps you understand, is it going to be practical to deploy a TAVI inside the surgical valve rather than needing to consider redo surgery. And it's also partly about what else might need to be done. Is there other significant valve disease or coronary disease that can't be intervened on unless you do open heart surgery? So that's my cop-out answer, sorry.
Brilliant. Yeah, I think there's no other questions, but that was a really fantastic grand round. Oh, thanks for that, Becky.
Thanks, I'm glad you enjoyed it. Yeah.
All right, if there's no one else, I think that draws this session to a close, but thanks very much, everyone.
No problem, thank you.
All right. Oh, I think Dr. Dickinson might have a hands up, Becky.
Sorry, does that mean
I did have a hands up because I just thought I might add a couple of words regarding the questions that were raised. Firstly, with medicating patients with aortic stenosis, as Becky said, quite often these patients have had some cardiac problems in the past, hypertension or perhaps other issues. So they had been on cardioactive medication for a while, whilst developing more advanced valve disease, but medication hasn't been adjusted. So what had been good for them 5-10 years earlier might not be very good for them at the point where when you are seeing the patient. And we still use, for example, ACE inhibitors in patients with severe aortic stenosis to support left ventricular function, particularly if they already have signs of impairment. But the doses may have to be revised. And one thing to bear in mind is that patients with aortic stenosis will have this very severe gradient across the valve, so the peripheral pressure will be lower than the pressure generated within the ventricle at the end of diastole, and that's what causes the problem. So if you give patient with severe AS a lot of vasodilating drug, you are effectively creating excessively high gradient over and above of what they already have anatomically. So you need to avoid combinations of vasodilators and drugs which deplete the volume. So if you give a severe AS patient a lot of diuretic because they are decompensating, they are in pulmonary edema, you need to think about perhaps taking off the amlodipine or reducing ACE inhibitors and trying to balance things out. Because what aortic stenosis patient does not tolerate very well is severe vasodilation, and that would, for example, include also severe dose of sedation or anesthetic drugs when they vasodilate very rapidly, because they haven't got compensatory mechanism to take care of that. And the other thing they don't tolerate very well is rapid fluid shifts. So if you either deplete them of fluid or significantly increase volume of fluid, they don't deal with that very well. And the other comment about the TAVI in TAVI or TAVI in previous replaced tissue valve is that it is becoming increasingly more common procedure. The data for that isn't as great as we would have liked to, but a lot of it, as Becky said, is based on anatomical circumstances. Some patients who already had a valve will have a valve which is slightly mismatched to the original valve. So you have mild degree of stenosis, even if you don't consider the actual narrowing within the cusps of the valve. So if you put another valve with the ring in it, you sort of shrink in the orifice further and further. So you need to look at the size of the original valve and the proportion to the cardiac size and the patient. You can't just be putting valve in valve and valve because they don't stretch beyond of what the ring size is. So in some patients, there might be limitations just because of some valve to patient size mismatch in the original procedure.
Thank
So
you.
these were the comments I had.
No, that's fantastic. Really helpful, actually, that.
Just to add, sorry, that reminded me that one of the key things at clerking patients level to remember is if you're seeing someone with ischemic heart disease, it's really important to listen to their heart sounds. Firstly, because they might have aortic stenosis and that's why they've got angina. Secondly, because if they have got aortic stenosis, you need to be really careful about giving them GTNs. That's one of those classic kind of vasodilating drugs that can cause, hemodynamic collapse in someone with severe aortic stenosis. So listen first before putting someone on a GTN infusion or giving them a spray.
Duly noted. That's great advice for juniors, actually. I think that's really going to help make people a bit more mindful of these things. All right. Katrina, have you got your hands up again, or is that the old hands up?
Oh no, I'm just a bit slow on the IT, so I haven't remembered to retract it. Sorry about that.
No worries. Well, listen, thank you so much, everyone. I really appreciate this. It's been really helpful.
Thank you very much.
Thank you very much.
Bye-bye.